So we can go to the 11th question. 70 years old man underwent total hip replacement 4 months ago and has experienced three dislocations rather. Radiographs reveals no failure of hardware, then a stable component that has abduction angle of 48 degree. That is normal. That is a normal abduction angle and degree and version of a 10 degree retroverted. We have to note that it is retroverted. What is the most appropriate treatment of the recurrent dislocation? So as the acetabular component is retroverted, we definitely have to revise the acetabular, revise the revision of the entire acetabular. We have to revise the entire acetabular component. Retroversion is not acceptable. The acceptable position is 50 to 20 degrees antiverted position. "60-year-old patient had the procedure shown in the figure 7 performed 7 years ago. When converting this patient to a TKR, what patellar problem is commonly encountered intraoperatively?" So we can see that earlier patient has underwent a lateral closing wedge osteotomy. So after lateral closing wedge osteotomy, patellar tendon length remains the same, but this bone length will decrease. So it will lead to patella baja. Patella baja is commonly encountered when converting to high tibial osteotomy. Patella baja mostly occurs because of scarring. During a minimally invasive total knee arthroplasty with a quadriceps sparing approach, the exposure is found to be limited and causing difficulties with jig alignment. What is the optimal next step? This is a minimally invasive approach, that is, they are doing a quadriceps sparing approach. The very next step we can do is conversion of the exposure to a standard parapatellar arthrotomy. We have to understand the different approaches. This is standard medial parapatellar. This is subvastus approach. This is subvastus approach. This is mid-vastus approach. This is the quadriceps sparing minimally invasive approach. So we have to go for a standard parapatellar approach. So going to the next question. When comparing, it's an irrelevant question, so we can shift to the next question. 45 years old with a history of sickle cell anemia reports hip pain for the past 6 months. A radiograph of the affected hip is shown in the figure A. So the following direction has been shown to be busted. Sickle cell anemia, we can understand that is a AVN. So uncemented in the 45 years old, we definitely have to go for uncemented metal and poly THR. Cemented is not acceptable. Hemi is not acceptable. Bisphosphonate observation definitely not acceptable. So we have to understand the Fickett staging system also. If there is bone collapse, Fickett stage is 3. If there is femoral head flattening, it is stage 4. If it is bicompartmental, that if the acetabulum is also involved, it is Fickett stage 5. All stage 3, 4, and 5, we have to go for, in both stage 4 and stage 5, we have to go for a total hip replacement. So next question. From the image itself, we can understand that in the supralateral there is too much bone loss in the supralateral aspect of the acetabulum. So we have to understand that this is a type 3A Paprosky classification. Type 3A Paprosky classification is treated with metal augments with a large porous coated hemispheric cup and bone grafting combined with screw augmentation. So this is a type 3A acetabular migration of the hip center in a supralateral direction. Preferred treatment option would be provide structural stability with the cup with metal augments combined with the bone grafting and cement reinforcement and screw fixation. If it is a if it is a type 3B, lastly for the type 3B defects, we have to go for a non-cemented acetabular devices combined structural allograft, structural augments, and reconstruction cage. You have to understand in and out for the Paprosky classification. Custom tri-flange acetabular components would be preferred for the treatment of type 3B defects where there is a disruption of medial wall. So supralateral migration, we have to go for metal occupants with large porous coated hemispheric and bond grafting combined with screw fixation. In total hip arthroplasty, which of the following techniques will lead to improved stability by increasing the abductor tension? We have already discussed that increasing the offset will lead to retensioning of the abductors, and it will increases the stability, improve the stability in the patient. Descendage, if we are increasing the offset, there will be prominence of the trochanter, and it will lead to trochanteric bursitis. Here we can see that horizontal offset is increased, it will cause us trochanteric bursitis. Radiograph of an otherwise healthy 62 years old woman who fell, and management should consist of. Here we have to understand Vancouver classification. Vancouver classification. We have to understand the Vancouver classification. There are three: A, B, C, and A means peritrochanteric area, AG means greater trochanter, AL means lesser trochanter. B1 is fracture around the stump with a well fixed stump. B2 is loose stump. B3 is without a good proximal bone quality. C is a diaphyseal fracture. We have to decide the treatment according to the classification. So this is a B2 with a loose implant and with adequate bone stock. So we have to go for a revision total hip arthroplasty with a cementless femoral component and adjuvant fracture fixation. If there is a poor bone quality, if it is type 3B, if there is a proximal bone that is poor quality or severely comminuted, we have to go for a femoral component revision with proximal femoral allograft or proximal femoral replacement. Next question. Here they are asking that the patient has underwent previously a surgery, and if you are going for a TKR, what sort of TKR will be doing? In this image, we can see that there is no patella, so patient has underwent a patelectomy already. So in patelectomy patients, posterior stabilized total knee arthroplasty is the preferred treatment. Patelectomy patients. So in this also, revision arthroplasty with a long-stemmed uncemented processes. Long-stemmed uncemented processes is indicated in type B2 Vancouver classification. This is the B2 Vancouver classification. So the answer is Vancouver B2. B2. If there is no proximal, here there is proximal bone stock, so we can go for a long uncemented revision on femoral side. But if there is no proximal femoral bone stock, we have to do an allograft reconstruction, or we have to do proximal femoral replacement surgery.